Welcome to It's Your Case, presented by VetCT.com. I'm Amy Zalcman, your radiologist on demand for this week. We're continuing with this month's theme of No Bones About It. Today's example is a 5-year-old male Labrador Retriever who presents for acutely being down in the hind end. He went outside yesterday morning and came back without being able to put weight on his right pelvic limb. He had radiographs performed at his primary vet yesterday, which were unremarkable, and developed explosive diarrhea overnight. He has not eaten at all today, and today he has lost the use of his left pelvic extremity. On orthopedic exam, he is very painful in his right stifle and left tarsus with palpation, and both are swollen and warm to the touch. He has had a tibial plateau leveling osteotomy of the right stifle and previously diagnosed with osteochondritis dissecans, or OCD, in his left tarsus, which was scoped. His current medications include Previcox, Tramadol, and Apoquil. He has had RADs performed of the stifle, the tarsus, as well as the lumbar vertebral column. If we begin with the lumbar vertebral column, what we observe is that there is marked narrowing of the L1, L2 intervertebral disc space, as well as increased opacification or sclerosis of the end plates. If we look with closer inspection, we do not observe that there is irregularity or lysis of these end plates. We do also appreciate that there is remodeling of the articular process joints as well, and this change is predominantly observed along the left side. Let's take a look at the right stifle. As we set up these images for evaluation, what we do notice is that a urinary catheter is in the plane of the urethra and overlies the patella and distal femur. We observe that there is increased soft tissue opacity within the capsule that results in distension of the caudal margin. We have moderate periarticular remodeling along the patella, the trochlear ridge, along the tibial plateau, and there is a generalized increase in soft tissue opacity surrounding the joint. There is no lucency associated with the screws or separation of the plate associated with the previously performed tibial plateau leveling osteotomy. If we take a slight step back, we do observe that there is an increased muscle mass relative to the left. However, the positioning is not symmetrical, nor do we have complete inclusion of the thigh muscles. So this is subjective at this point. The popliteal lymph node is incompletely defined, but subjectively enlarged. On closer inspection of the tarsus, there is very mild remodeling of the craniodistal margin of the tibia. Let's take a look at the left. The left stifle is within normal limits. The popliteal lymph node is symmetrically relatively enlarged in comparison to the right side. As we then start to inspect the left tarsus, we observe similar changes to the right stifle in that there is a marked amount of intercapsular soft tissue opacity. So this is consistent with a large volume of effusion. However, this is probably more severe than what was observed in the right stifle. There are multiple mineral foci superimposed with this space as well. So likely within the capsule or along the capsular margins. We also have marked thickening of the soft tissues surrounding the joint space as well, so outside of the boundaries of the capsule. We do have an abnormal shape of the proximal talus or the trochlear ridges, and flattening of the tibia as well, which results in widening of this joint space. And this is very consistent with the previously diagnosed osteochondritis dissecans. If we look closer at the subchondral bone margin of the distal tibia, we do have a bit of loss of the cortical bone, and this can be associated with previous scoping, or this can represent current lysis associated with this active inflammatory process that is currently ongoing in this joint space. Our principal conclusions for this patient are narrowing of the L1, L2 intervertebral disc space consistent with chronic intervertebral disc degeneration. We can't particularly identify whether or not there is spinal cord compression without the absence of myelography in radiographic technique, or we could consider a computed tomography for further evaluation. MRI is also a very viable option. We also identified articular process osteoarthritis. In the right stifle, we have moderate to marked joint effusion and periarticular swelling with marked osteoarthrosis. Acute septic arthritis superimposed with chronic degenerative changes cannot be entirely excluded. The left tarsus indicates severe joint effusion and periarticular swelling. We have chronic subluxation of the tibiotarsal joint, which may be secondary to historical OCD of the talus, or may be associated with previous trauma. The osseous changes are compatible with chronic arthritis as well as concurrent septic arthritis. Possible popliteal lymph node enlargement is bilateral and may represent reactive hyperplasia. There is mild right tarsal osteoarthrosis. So what we then deduce is that there's both marked intra and extracapsular changes of the left tarsus in conjunction with the subtle subchondral cortical lysis, which heightens our concern for a septic process that summates with the chronic degenerative changes. Septic arthritis cannot be excluded in the right stifle and should be considered as a differential given the reported clinical symptoms. However, there are also marked arthritic changes. These changes can be due to the previous cranial cruciate ligament rupture and secondary TPLO. The lesion at L1, L2 may also relate to the inability to stand in the pelvic extremities. However, as mentioned previously, spinal cord compression warrants additional imaging for further characterization. Arthrocentesis was performed in the right stifle and was found to be hemodilute and therefore inconclusive. The joint tap from the left tarsus showed septic arthritis as indicated by intracellular bacteria. Be sure to view the full report associated with this case. Thanks for listening, and remember, it's your case, so please post your questions on social media.